The broadcast is now starting. All attendees are in listen-only mode.
Good evening, ladies and gentlemen. Welcome to the webinar on Fracture Cascade and Secondary Fracture Prevention. My name is Masaki Fujita, and I am the Science Project Coordinator at the International Osteoporosis Foundation in Nyon, Switzerland. I am also the CTF Program Global Coordinator. For those who may not know, the Capture the Fracture program was initiated in 2012 with a mission to help facilitate the implementation of FLS globally for secondary fracture prevention. I am happy to moderate this webinar and introduce you to our main speaker of the day, Professor Thierry Thomas. Professor Thomas is a professor and head of rheumatology department at the University Hospital of Saint-Etienne in France. He is an active member of the Capture the Fracture Steering Committee. He is also the past president of GRIO, a major French patient society on osteoporosis. He is an expert in FLS and post-fracture patient care, and he was instrumental in establishing an FLS in 2003. Before I begin, I'd like to inform you that attendees are automatically muted. For any questions you may want to ask, please feel free to type your questions into the question box of the GoToWebinar panel. Questions will be collected throughout the webinar, but will be voiced towards the end of the webinar. Now, on to you, Professor Thomas.
Thank you, Masaki, for these few words of introduction. I would say hello to all of you that are attending this webinar on fracture cascade and secondary fracture prevention. So my presentation will last for about 45 minutes, and we will have time for question and answers at the end of this session, as Masaki told you. Here are my disclosures. So as you know, the risk factors in osteoporosis are numerous. The most obvious one is bone mineral density, but we have many others like the glucocorticoid therapy, gender of the patient, the shape of bone, and there is a lot of interactions between all of these risk factors, and these interactions are complex. The complexity is even higher because when we talk of risk factors in this disease, we can sometimes talk about risk of having a low BMD or the risk of having a fragility fracture. Actually, the last one is probably the main issue in clinical practice, because when we try to treat the patient, our main objective of the treatment is to reduce the risk of having either the first or the additional fragility fracture. Nowadays, the initiation of this treatment have to be done in patients that have been defined of having a high risk of fracture, because we know that it is in this specific subgroup of the population that the treatments are very effective, with a good ratio benefit over risk. And we have been using in different countries tools to address the level of the risk of fracture. One of these tools is the FRAX tool that is promoted by the IOF organization. What is interesting in this FRAX is that the algorithm combines all the risk of fracture, and definitely it shows how having a prevalent fracture definitely increases the risk of incident fracture. If you take the example of this patient that is 74 years old with a normal BMI, currently smoking, without any BMD calculation, you can assess his absolute risk of fracture over the next 10 years for hip, and you see that it's about 6%, and for major osteoporotic fracture, you see that it's 12%. But if now you consider that this lady had a previous fracture in his past history, you see that the risk of fracture is almost the double, regardless of the other risk factors. The risk of incident vertebral fracture in women who had prevalent vertebral fracture increases over time, as is shown in this old paper. What is also important that this effect of having a prevalent fracture is not only time dependent, but it's also, I would say, dose dependent. And when I say that, I mean that the risk increase with the number of prevalent vertebral fracture. I show you here the result of a large cohort looking at the absolute vertebral fracture risk over the level of BMD T-score at the femoral neck. And as we all know, the risk, the absolute risk, increases with the decrease of the femoral neck. Now, if you split the population in two subgroups, one with the women who had prevalent vertebral fracture and those who had no prevalent vertebral fractures, you can see definitely that there is an independent additional risk of having a new vertebral fracture compared to those who had no prevalent vertebral fracture. And again, if you look at now the number of prevalent fracture, you see that going from 0 to more than 3 prevalent vertebral fracture, you see that the absolute risk of having an additional vertebral fracture goes up from about 10% to almost 50%. The last chart shows that in addition to the number of prevalent vertebral fracture, the severity of the vertebral fracture has also a role in the subsequent risk of fracture. Let's take an example. So this clinical case, this is Mrs. Smith. She's 70 years old. She has actually some back pain last year. She did an X-ray, but nothing much was done. And she visits her GP because she complains of severe pain between the shoulder blades while carrying her shopping bag. She had no real improvement after having taken acetaminophen, but a few weeks later, pain decreased, and 2 months later, she had full pain recovery. She noticed that actually she lost 3 centimeters in height. She just received calcium and vitamin D. And 1 year later, she visits again a doctor, and she was complaining of acute back pain that was now located at the lower part of the thoracic spine. And the clinical examination was defined that she had severe pain at the T11, T12 level. So new X-ray were performed, and I will show you the X-ray that were performed at the very beginning. There was actually a T6 fracture that was not clearly emphasized by the conclusion of the radiologist, and nothing was done at that time. 1 year later, so at the T0, when she received calcium and vitamin D, she actually had a crushed vertebral fracture at T9, and then 1 year after, she had a third vertebral fracture at T11. And this is definitely this kind of subsequent events of vertebral fracture that we could define as fracture cascade, a term that was indeed promoted and proposed by Pierre Meunier almost 30 years ago. What is very important in this notion of fracture cascade is that having one fracture actually tremendously increase the risk of having another fracture in the following months after the first event. That's what we call now an imminent risk of another fracture. And this has been shown, for example, in this paper that pooled patients that were included in several research clinical trials, but just received placebo in these trials. And in the year following vertebral fractures, in this population, about 20% of those women had a new vertebral fracture within that period of time. And then if you talk now about the number of them that had either a vertebral or a non-vertebral fracture, actually 25% of them had a new fracture. This imminent risk of another fracture has been shown as well in the follow-up of cohorts on the long term. We can see that if you consider the relative risk of having a fracture after a first one, over time, the relative risk of having either a vertebral or a non-vertebral fracture is roughly around twofold, and it remains so for a very long period of time, up to 20 years of follow-up in this study. But there is a super risk of having an additional fracture in the 1 or 2 years following the first event. So there is definitely here a period in which we should appropriately manage the patient. If we talk about this vertebral fracture cascade and we try to identify the mechanism that lead to this cascade phenomenon, there are a couple of altered properties that are specific to this osteoporotic population. Obviously, one of the major mechanisms are related to the degradation of the bone property. There is decrease in bone density and or the bone quality. There is an alteration in the distribution of bone mass within the bone, and there is also a deterioration of the microarchitecture of the trapezial bone of the vertebrae. What is also important is the fact that after having a vertebral fracture, there is impairment of the neurophysiological properties, and it has been shown that this first event will lead to a loss of trunk muscle control, decrease in the quality of balance, and these two altered property will lead to fear, especially fear of falling and fear of moving, and so there is alteration of functional mobility. The third part of the cascade phenomenon is related to spine properties, especially when we deal with the specific vertebral fracture cascade. When you have already one vertebral fracture, you have alteration of local spine properties, namely the vertebral macrostructure, and also the alteration of the intervertebral disc that are very often already modified prior the occurrence of the fracture. But there is also a modification of the spine as a global part of the skeleton, with a modification of the spinal curvature that will induce changes in the way the spine is loaded, and a modification of the way the trunk muscles perform, with weaknesses of this muscle. This modification of the spine shape is very often related to hyperkyphosis. And there are several papers that show that hyperkyphosis, actually of any etiology, has been associated with a decrease of the extensor muscle strength, unstable gait, increase in body sway, decrease in physical and pulmonary function, chronic pain, and most importantly, in this notion of fracture cascade, an increase in spinal loads and a change in the way the vertebrae are loaded that will tremendously contribute to the vertebral fracture cascade. Let's take another example of this woman that had already 2 vertebral fractures at the levels T7 and T8, and nothing was done at that time. And 1 year later, she came back with a 3rd vertebral fracture at the level of T6 that actually occurred at the anterior and upper part of the vertebrae, probably because the way the upper part of the body loaded this specific part of the T6 vertebrae was definitely changed by the overall shape of the thoracic spine. I talk about the vertebral cascade phenomenon, but we could certainly expand the fracture cascade concept to the fact that having a non-vertebral fracture will actually increase the risk of having a vertebral fracture. And this has been shown in several studies, especially after having a hip fracture, but it's also true after having hip fracture, with a 2-fold increase of having a vertebral fracture over time. And this is true for all the women that are over 60 years of age. Let's take a 3rd example of this. Mrs. Monk, she's 65 years old. She had a wrist fracture after a fall from her height, so it was definitely a fragility fracture. And she had several risk factors of having both osteoporosis and having a fracture. Her mother had actually a hip fracture. She was a smoker, and she had a very low BMI of 18. 3 years later, she felt again on her buttocks with, at that time, back pain at the lower part of the thoracic level. And performing X-ray, it was observed that she had a vertebral fracture at the L1 the L1 level. It is not always easy to see that at this level on standard X-rays, because it's usually either at the bottom or the upper part of the vertebrae. And this is definitely a level at which vertebral fracture assessment associated with DXA measurement that is very efficient to show this kind of vertebral fracture, as it is shown in the image in the center part of the slide. Obviously, the increased risk of fracture related to a previous non-vertebral fracture is related to different aspects, the bone fragility, of course, but also to the occurrence of falls. But intriguingly, I put some emphasis on the role of hyperkyphosis in the vertebral fracture cascade. But there are recent papers showing that indeed hyperkyphosis also induced the risk of non-spine fractures in older community dwelling women. This study was conducted in the soft cohort, and the author showed that not only the curve angle that was measuring the kyphosis, but also the changes in this angle over time was an independent predictor of having a prevalent non-vertebral fracture, regardless of the number of prevalent vertebral fracture. And if we go back to our third clinical case, you can see this patient that had only conservative treatment for controlling pain. She was discharged from hospital 1 week after having her L1 vertebral fracture. But again, she fell from a height, inducing a trauma to the greater trochanter, and she had a hip fracture. And it is known that having a vertebral fracture increased the risk of having a hip fracture. There are several papers demonstrating this risk of having a subsequent fracture at the hip or the vertebrae, whether the first fracture was located either at the vertebrae or the hip. And what you can see as it is highlighted in this table is that the increase of subsequent fractures is always roughly around twofold. And moreover, what is it observed that this increase in the risk of having either a vertebral or a hip fracture after any first fragility fracture is independent of age, and is probably even higher in patients that are younger, in the range between 65 and 74 years of age. Having a first fracture, as I showed, increase the risk of having additional fractures, and this occurs in a short period of time. That's what we call the cascade, the fracture cascade phenomenon. But it's not the only problem of having a first fracture. The second very important problem of having a fragility fracture is the increase of the mortality rate that follows the occurrence of the vertebral fracture. And again, this phenomenon is dose dependent, with an increase of the mortality rate with the increase of the number of vertebral fracture, and it has been shown in this study. The increase in the mortality rate is also time related, but it actually decreases with time, as it is shown in this South Korean study with nationwide data. And you can see that the standardized mortality rate, it's definitely increased in all age ranges. And actually, again, the mortality rate is definitely more increased in the patients that are the youngest of these cohorts. But with time, going from the upper part of the graph to the open triangle line, you see that from 3 months after the vertebral fracture to 2 years after the vertebral fracture, the standardized mortality rate was still increased, but not to a similar extent. This suggests definitely that there is a relationship between the occurrence of the fracture and the increase in the mortality rate. This has been shown in many other epidemiological studies, and one of the most obvious demonstration was coming from the DUBO study with this cohort representative of almost the entire population of the DUBO County. And what the authors of this study demonstrated is that regardless of age, the patient who had major fracture had a survival probability that was lower than the general population. And this was true especially for fractures at specific bone sites, namely the hip, as we know, the vertebrae, as we just discussed, but also at two other sites that are very important in the course of the disease, the upper part of the humerus, that is the fourth non-vertebral bone site for a fracture, and also the pelvis. And after this publication, we had several publications that confirm the fact that for elderly population, having a pelvic fracture is a very severe event with an increase in morbidity and mortality as well. What is very important to add in this notion of risk of mortality associated with the occurrence of fragility fracture is that there is, over time, no improvement in the standardized mortality rates after major fractures. And this has been shown again from this cohort of DUBO, and what the investigators did in this publication, they split their cohorts in two subgroups, those that were born before 1930 and those that were born after 1930. And they looked at the standardized mortality rates after all fractures, hip fractures, and so forth in two different periods. And whereas there was a decrease in the general mortality rate of their population with a better health of the population over time, there was no change in the standardized mortality rate after major fractures in these two subgroups. So I show you several data demonstrating the fact that one fracture will induce the risk of subsequent fractures, and sometime in a cascade phenomenon. I showed you that having a fracture, especially at specific bone site like the hip, the vertebrae, the pelvis, and the humerus, increase the mortality rate. But having a fragility fracture also alters quality of life as well as morbidity. It is very well known for hip fractures, as several publications demonstrated that the decline in function was 32% at discharge after this kind of fracture, and that 30% of the patient after having a hip fragility fracture were still unable to walk independently 1 year after the event. So this is a very important aspect of the fragility fracture that, of course, has to be well taken in the burden of the disease. And what is also important is the excess of mobility that is related to the fragility fractures. In this little chart, you can see in the dark blue that over time, of course, the morbidity of the population increases, and these increases can be attributable to aging. But if you consider different fractures that could occur during the course of the osteoporosis, starting with wrist fracture in the 50s, and then fragility fracture like vertebrae or humerus or the wrist between the age of 60 to 80, and at the very end, the tremendous increase of hip fracture occurrence after the age of 75 to 80, we can consider that the morbidity at the beginning will return after a few years to the level of the general population. But if you enter, and if the patients enter in a fracture cascade phenomenon, then the excess morbidity will accumulate over time, because this morbidity will not return to the level of just aging-related morbidity. So having a fragility fracture is having all of that, increasing pain because of the fracture, decreasing the function of the patient, but also impairing his quality of life, increasing morbidity and mortality. And this multi-factorial phenomenon after the fracture has to be well explained to the patients that usually consider having a fracture as a very simple and normal event, especially after a fall. So we don't have to miss the opportunity of preventing a secondary fracture. And our data showing that actually half of the patients that have a hip fracture had a wrist or vertebral fracture in the past that were not well managed. That's where the Fracture Liaison Services can play a great role in identifying the patient at risk of having a fracture, and then running investigation, evaluating their bone status, and initiating appropriate treatment. The Fracture Liaison Services probably have to monitor the patient over time with the collaboration of primary care. And if this loop is well managed, then it will lower the rate of subsequent fracture with fewer secondary care admission, fewer care home admission, and it will improve the health of the patient. It will decrease the need for family support, and it will definitely decrease the need for healthcare support with economic savings for the entire population. I will just draw your attention to this recent paper that looking at different hospitals in the UK was able to demonstrate that comparing before and after the implementation of fracture liaison services in this hospital, they were able to demonstrate that this appropriate management of the patient was able to decrease the subsequent mortality following hip fracture from about 20% after within 3 days to 16% within 1 year. And what is striking in this study is that just through an FLS, the better management of the patient did almost as well as what is considered as the gold standard in this situation, namely the organization of also geriatric department. So yes, it is an effective management of the patient, and not only to decrease the risk of additional fracture, but also to the consequences of this fracture. That's the reason why the IUF puts a lot of effort to facilitate the implementation of the fracture liaison services over the world through a program that is called Capture the Fracture. Here is the steering committee of this program. Is led by Serge Ferrari, Kassim Javed, and Christina Akesan. The key aims of this program is first to be the global voice of all those who want to have or implement an FLS. It is also to drive national and international policies for this management and to ensure the good quality of this FLS. It's also there to provide support for those who would like to implement an FLS in their own institution. And it's coming along. We already have like 234 fracture liaison services that are mapped through the Capture the Fracture program, and that have been evaluated by our group. And if you consider that there were very few stars like a couple of years ago, I think it's a good achievement on the road of improving the management of patients. Of course, if you now consider the number of FLS that should be set up over the world, we are probably around 1% of what we should do. So there is still to do. So do you want to run an FLS? If yes, we do believe you have to join our program. And the major part of the program, beside being mapped on this on our website, that is quite important, especially for those who will have to pay for your coordinator. What is very important is what we call the best practice framework. And if you go to the website, you will be able to fill up a questionnaire that will assess different standards we set up at the international level, defining a best practice for an FLS. Here are the certain criteria we define, the identification of the patient, for example, but also what is the most critical standard is probably the ratio of the patient the FLS is able to evaluate, and obviously the higher the better. So we assume that if you're able to evaluate 90% of the patient visiting your institution for fragility fracture, you deserve a gold for this standard. What is also important, especially considering the fracture cascade, is the time frame in which you are able to assess those patients, and we consider that what would be very, very good is to assess this patient within 8 weeks following the fracture event. Most of the time, the FLS are considered to be there to manage patient after a non-vertebral fractures, because nothing was done in the past for those patients. But as I mentioned earlier, it is very important to assess any fracture regardless of its location. So the FLS are also there to identify and manage patient after having a vertebral fractures. And this is true for a patient with clinical vertebral fracture, and it is done most of the time by the appropriate department. But what should be the gold standard in this management of patients with vertebral fracture would be to identify all the patients that have a vertebral fracture and visit the radiology department, especially those that have vertebral fracture on any imaging that are not performed for showing a vertebral fracture, but actually did, like for example, CT scan of the lung for patients with lung diseases. So what could be an optimal fracture liaison service would be an FLS in which the patient could enter either from the emergency room, the orthopedic department, especially for those who had a clinical fracture, either vertebral or non-vertebral fracture, but also from the radiology department for all of those who had a vertebral fracture that was fortuitously discovered on any imaging. And those patients, whether they go back home or go in a rehab department, have to be identified by the coordinator of the FLS and then get a visit for bone evaluation with a DEXA and a bone specialist visit. And if needed, then information has to be given to the patient. That is very important. The treatment has to be initiated by the FLS, and information and coordination has to be organized with the GP for the follow-up. But the FLS has also to deal with the risk of falls, and the appropriate management of the patient is not only the pharmaceutical management of the bone disease, but is also the prevention of future falls. So to conclude, I would say that the fracture cascade is a clinical reality, and when a first fracture occurs, the risk of recurrence is maximal in the next first month. So the first fracture should be definitely the last one, and appropriate measures, pharmacological treatment have to be considered, as well as management of fall. And FLS has been demonstrated as a model of cost-effective management of those patients. I thank you for your attention, and I'm ready to answer to your question.
Thank you very much, Professor Thomas, for your presentation. You have explained in detail what the term fracture cascade means and what it entails at the level of patients. The three clinical cases you presented underlines a strong correlation between primary non-vertebral fracture or vertebral fracture and the occurrence of a secondary fracture in many cases, which are vertebral fractures. Now, the significant effect on the mortality rate following fractures is evident from clinical practice and literature. Finally, you also propose FLS as the most clinically effective and cost-effective model in dealing with this unmet medical need. Now, I would like to move on to questions, and we have received a few questions during the presentation. So, starting with question number 1. You have discussed in your presentation several clinical fragility fractures. What are other clinical fractures that we should not miss?
I think I will say again that what is very important are the four major or severe fractures that first increase the risk of a new fracture, but also increase morbidity and definitely increase mortality in the year following the fracture event. And I will say again, these four different locations are the hip, the humerus, the pelvis, and of course the vertebral fracture. We shouldn't miss these four severe fractures. But we also have to well manage patients with the less severe fracture in terms of consequences, like the ankle or the wrist, because this patient having fracture at the wrist or at the ankle may have bone fragility. They may have not bone fragility, and that is important that they visit a bone specialist, especially when bone mineral density, for example, is quite normal. So we know, even at the age of 60 or 70, that these fractures could be just traumatic fractures. But definitely they could be like the first event of a fragility fracture of the course of osteoporosis. And as I showed, the earlier we're able to identify patients with bone fragility and to decrease the risk of additional fracture, the better we manage the patient.
Thank you, Professor Thomas. Moving on to second question. Why is fracture risk higher during the first 2 years after the first major osteoporotic fracture?
That's an intriguing question. Regarding non-vertebral fractures, I think that there are several mechanisms that lead to this super risk of fracture in the year following the first one. These mechanisms are related to first the loss of mobility of the patient, because if he has, for example, a hip fracture or a humeral fracture, it will be difficult for him to walk well during the first months following the fracture. There is also a fear of falling in this patient that most of the time did fall down when they had their fracture. There is very often a loss of muscle strength because of the immobility related to the first fracture event. If you consider now the vertebral fracture, I think that the change in the shape of the spine, the global spine, is a key question, and I say that because we all know that the risk of a subsequent vertebral fractures is very often nearby the very first vertebral fracture, and you have to consider that if you change the shape of the spine, you will suddenly change the way the body of the adjacent vertebrae is loaded. And the vertebrae are, especially the body parts, is mainly a trabecular network. This network is anisotropic. It means that it has a specific orientation of the trabeculae, and this orientation were defined over time to respond to a specific way of loading. If you suddenly change the way the load is applied on this network, we'll have additional bone fragility until the network will adjust to this new loading way, in a sense. So I think there are probably other reasons, but I think there are the major mechanism that lead to this super risk of fracture in the year following the first one. Do you have other question?
Yes, we have one. Unfortunately we only have time for one or two more questions. But
Okay.
the one question is, one person is asking you to go back to the FRAX model and to show if nutrition is questioned in this model. Isn't the role of vitamin D and calcium supplements important for muscle tones and for preventing falls?
There's no direct measurement of nutrition in the FRAX, and I don't think there is any other tools that deal with this aspect. There are, of course, indirect ones through the BMI. Calcium and vitamin D are good for prevention, and it has been shown that they are a risk factor of having bone loss. Because if you have not enough calcium intake or a low vitamin D, you will induce, for example, a hyperthyroidism that will increase the bone loss. So if you give appropriate calcium intake, not necessarily through pills, but through nutrition, if you have appropriate vitamin D level, you will suppress these two risk factors. So you will probably be effective in lowering the rate of bone loss. That's prevention of the disease. But as soon as someone has a bone fragility that is sufficient to induce a fracture, or a very important bone loss with a low BMD, just calcium and vitamin D is not a treatment appropriate for the patient to get a better bone strength and decrease the risk of fractures. That has to be said, and that has to be said to our colleague as GPs, because we see very often in the past years a shift from appropriate anti-osteoporotic drugs to just calcium and vitamin D. And that's not what we have to do. If we do that, it has to be just in combination with appropriate treatment. But calcium and vitamin D, again, is just a preventive treatment.
Thank you, Professor, for emphasizing that point. We only have a few more minutes, but one last question. Wrist fracture could be a signal for osteoporosis. Now, do you believe that with the onset of radial fractures, should this be a signal to initiate treatment for osteoporosis independently of BMD or other factors for osteoporosis?
I can take the example of our new guidelines in France. We consider that if you have a severe fracture, and again, I said these 4 bone sides, hip, vertebrae, pelvis, humerus. If you have those fractures in just a fall from height or without any fall, it means that the bone is fragile. So if the bone is fragile, you have to treat the patient with anti-osteoporotic drugs to improve his bone strength and decrease the risk of additional fracture. And in our guidelines, we just ask to perform BMD prior treatment, especially to have a level of BMD to appropriately monitor the patient after you start the treatment. There is probably one situation that may draw additional attention from a bone specialist is the situation in which the patient that have one of these 4 bone fractures have a normal BMD, so a T-score above -1. Because it is very surprising that someone that is above 70 years old has one of these fractures and a normal BMD, and there's probably something going wrong in the bone. So it's probably a different bone disease than just osteoporosis. But for all the others, and vast majority of them will have a BMD by below -1, we should treat them.
Thank you, Professor Thomas, for answering the last question of this webinar. Now, with this, I would like to thank you very much for your participation in this webinar, everybody, and we hope that it was an educational one for you. We will post recordings of this webinar along with the slides on our website. You will find them under capturethefracture.org/webinar. Now you will be prompted to fill in a survey after this webinar. We'd highly appreciate your input and comments as we continuously like to deliver webinars that meet your needs. We also like to take this opportunity to thank our sponsors, Amgen and UCB. Without their support, this initiative would not have been possible, and we highly appreciate their support. Last but not least, if you have any questions, comments, please do not hesitate to send them over to capturethefracture@iofbonehealth.org. With this, I'd like to conclude today's webinar. Thank you very much and goodbye.
Thank you. Goodbye.